Good morning. We are especially pleased to welcome again Dr. Alaa Abdelgalil, the head and neck imaging leader in Rigmore Hospital. In one of his captivative and well-illustrated lectures. And today, Dr. Alaa will navigate through the spectrum of non-neoplastic diseases of the paranasal sinus. It's yours, Dr. Alaa.
Thank you so much. Welcome again, everyone. We're discussing today non-neoplastic lesions of the paranasal sinuses. So in this lecture, we will be going through the sinonasal obstructive patterns. After that, I'll show you some cases. And we'll finish off by a take-home message. So we have 5 different sinonasal obstructive patterns, and these are the infundibular pattern, the osteomeatal pattern, sphenoethmoidal recess pattern, sinonasal polyposis pattern, and finally the sporadic pattern. What do we mean by infundibular pattern? So as the name implies, the blockage will be at the level of the maxillary ostium or the ethmoidal infundibulum, which means that we will have only one sinus opacified, and this is your maxillary sinus. The osteomeatal pattern, the blockage will be slightly more proximal, which means that the osteomeatal complex will be blocked, and this will lead to opacification of 3 sinuses. All of them are draining into the middle meatus. These are the maxillary, the anterior ethmoidal air cells, and the frontal sinus. The sphenoethmoidal recess pattern, this means that the blockage is within the sphenoethmoidal recess. This is above the superior meatus, which means that we will have 2 sinuses blocked. And these are the sphenoid sinus and the posterior ethmoidal air cells. Sinonasal pattern, or obstructive pattern, sinonasal polyposis. So this is a very peculiar pattern of blockage. The sinuses, all of the sinuses will be full of very dense polyps. And this will lead to expansion in the sinuses. So this means that the lamina papyracea will be displaced slightly laterally. And because of the density of these polyps, you'll find that the maxillary ostium and ethmoidal infundibulum will be widened. And you will get almost most of the nasal cavity will be blocked by the polyps as well. Apart from usually, you'll find that the inferior aspect of the nasal cavities are spared. Because of the high vascularity in these polyps, you'll find some rarefaction, osteolysis of the bones. So you'll find very thin lamina papyracea. You'll find very thin, rarefied nasal septum as well. Sporadic pattern is anything else, apart from these 4 obstructive patterns. Now, let's move on and discuss some pathologies. The first pathology, now we said we're discussing just non-neoplastic problems. Infection. Just a few important points about infection in the sinuses. Imaging is not required in the acute setting. Okay, so if you find a patient with acute sinusitis, why do you want to see it? We know the diagnosis, right? It's a clinical diagnosis. The patient should have antibiotics and off you go. However, whenever I see a referral from an ENT surgeon asking for imaging in a patient with acute sinusitis, I know what they are looking for. They are looking for a complication. Okay, even if they don't openly say it in the referral form, you know what they're looking for, that something is not right. The frontal and ethmoid sinuses, if there's infection there, these can easily spread, especially in children, into the ethmoid, into the orbital cavity or the cranial cavity. If we're suspecting osteomyelitis, MRI is way more sensitive compared to CT. Let's see a few examples here, a few cases of infection. Patient with acute sinusitis, but now we know that there's something wrong happening. Facial swelling, we shouldn't get that in just simple acute sinusitis. So the typical appearance of sinusitis, you'll find inflammation in the sinus, opacified sinus, air fluid level, thickening in the mucosa, and the sinus will be full of just gunk, right? But why is this patient presenting with facial swelling? Look here, what's that? So this is cellulitis in the nasal soft tissue. If you look carefully, what is that? This is a subperiosteal abscess in the nasal aperture, right? On the sagittal view, you still can see it here. So this means that this is no longer take a pack of antibiotic and go home case. It is a theater case, right? Patient with left periorbital cellulitis, sepsis, and confusion. This was a young boy, And here we can see opacification in the ethmoid sinus and the anteroethmoidal air cells on the left-hand side. Even in the bone window, you still can appreciate something wrong happening in the superior medial corner of your orbit, right? Which means that the infection has spread from the ethmoid into the orbit. If you look more carefully, what's that? What's happening here? There's erosions in the roof of the orbit. And once you see that, you need to check what? The cranial cavity. What's happening here? This is a huge intracranial abscess. Is it subdural or epidural? So this is limited by the falx, so it's following the falx. So it can't cross the midline, which means that this is a subdural abscess. Is it really important to differentiate on our report, is it subdural or epidural? It is, because if the pus is in the epidural space, the surgeons will just have to open the calvarium and they will find the good stuff oozing out, right? If it is subdural, they will have to open up the calvarium and the dura to find their treasure. Another patient with frontal headache and frontal swelling. We have opacified frontal sinuses, and the infection has spread to the cranial cavity. And again, these are subdural abscesses, not just an epidural abscess. Why? Because they are following the falx. Okay, they are not bound. So they are bound by the falx, by the dural reflection. So it's not epidural, it's subdural. And if we look carefully, why is this patient presenting with facial swelling? Because of that. So we have infection in front of the calvarium, infection behind the calvarium or deep in the cranial cavity. So the bone in between must have also some sort of infection. And this is osteomyelitis. And this is what we see in Potts-Puffy tumor. So you need three things. You need osteomyelitis, abscess outside, abscess inside. It's not a tumor, it's just infection. Patient with maxillary sinusitis, left proptosis, and periorbital pain. So we have opacification in the left maxillary sinus, which has been ongoing for a while, but the sinus wall is thickened, and we can see the bone-in-bone appearance because of the periosteal reaction. And if you look carefully at the pterygoid process, it is squeezing in between a small, important space. This is your pterygopalatine fossa. Compare it with the other side. The pterygopalatine fossa is squeezed, narrowed. This is where the V2 is, right? Pterygopalatine ganglion. Look how elegantly the infection will be seen on MR compared to CT. High signal intensity in the hyperostotic walls. The infection has spread into the orbital cavity around the optic nerve in the orbital apex, spread also into the masticator space, into the skull base. You'll never see that on CT. You don't want to wait until you see changes in the skull base on CT to make it like a diagnosis of osteomyelitis. Just bring the patient back for MR. So chronic infection in the sinuses can cause osteomyelitis in your skull base. Now let's discuss a different type of infection, and this is the fungal infection. A few important points about fungus. It almost always happens on top of a chronically inflamed or chronically blocked sinus. On CT, it will be very hyperdense. I'm not talking about hyperdense, just slightly hyperdense. It's as dense as bone. Okay, don't overcall it. So you need to see high density like bone because of the iron and manganese contents inside the fungus. And that's why you should never trust a T2 in your sinuses. Why? Because again, the ferromagnetic effects of the contents, you will never be able to tell on a T2 whether this is just normal air or it's the fungus itself. And if the patient is immunocompromised for whatever reason, immunosuppression happens, the fungus can take the opportunity and starts invading. And nothing can stop a fungus, just like a tumor. However, very important to note that the fungus will never enhance. Tumor will. Okay, this is a very important differentiating point because if it invades, you will never be able to tell on your CT if it is a fungus or a tumor. You need to bring the patient back for an MR. Just a few examples. This is an asymptomatic patient, head injury, and we just found something by chance. So what could you see there? Can you see the density inside? This is what I'm talking about, very, very dense, like flakes of bone inside this fungus ball. And this is actually the mycetoma itself. On a background of a blocked sinus, how do you know that this is chronically obstructed sinus? Because of the hyperostosis there, right? Opacification. But the patient is completely asymptomatic, so this is a simple mycetoma. It's not causing problems. Patient with chronic left epistaxis. So we know now that there's something else happening. There is a complication of fungus, because I'll show you now why we said it's a fungus. This is the MR axial T2. You can see, again, chronically blocked or inflamed sinus. You can see the hyperestosis in the walls, high signal intensity. So this is chronic osteomyelitis. And can you see anything in the cavity of the sinus itself, apart from the mucosa, which is very thick? You can't really tell. Is this just gas, or is it something else? Okay, so here, can you see that? There's a ghost of something, shadow. But you can't make a definite diagnosis. It could be just some artifact, right? That's the T1 without contrast. See, never rely on a T2 in sinuses. If you skip the T1, you'll be missing a lot. And that's the post-contrast. It's not enhancing, so this is fungus, but the patient is presenting with what? Left epistaxis, so we need to be a bit cautious. Why is this patient coming with epistaxis? The fungus has gone wild. Can you see the medial wall of the sinus? It's eroded, and this is what we call chronic invasive fungal sinusitis. Another patient with the same pathology, weight loss, anosmia. And here the fungus has infiltrated the medial wall, on a background of a chronically blocked sinus again, and look where the fungus has gone now. Upwards. So we have the cribriform plates invaded bilaterally, the nasal septum invaded, and the fungus has gained access to the cranial cavity now. So this is a neurosurgical problem now, not an ENT problem anymore. Another type of fungal sinusitis, patient with chronic headache, nasal congestion for years, and left proptosis. So what could you see here in this T2 axial? Just some mucosal thickening, right? But there's expansion, which we can't really explain on this image, right? All the sinuses are expanded, so why? But now we know, never trust a T2, right? Look at the T1. This is not gas. Something else inside the sinus. Okay? Give contrast, no enhancement in the contents. The mucosa will be enhancing anyway because it's inflamed, that's fine. And again, look at the T2 coronal. Is this gas? The same patient's CT. Wow. Impressive, right? So this was not gas. See how T2 can be very deceiving. And can see the sinus expansion on the coronal. Again, this is the same level of the T2 image that I showed you in a minute ago. And here you can see the hyphae of the fungus itself, very dense. And the mucosa is actually less dense than the fungus itself. And you can see the expansion in the walls. Can you see how expanded the sphenoid sinus is? The cellus turcica is completely squeezed upwards. And this was what we call allergic fungal sinusitis. Now, a different topic, troublesome tooth. Problems in the teeth causing issues in your maxillary sinuses. Periapical infection in the maxillary teeth can cause maxillary sinus problems. Management is completely different, so you will never consider FES for these patients. You'll consider referring these patients to the max-fac surgeons or the dental surgeons. Any other dental disease can also affect the maxillary sinuses. And usually CT will be enough to make a diagnosis here. So this is a patient with chronic sniffing, postnasal discharge. So what's wrong here? We have mucosal thickening, so this looks like sinusitis, but why is this patient getting the sinusitis on only one side? Because we have periapical infection in a tooth, in a molar. And there's a defect in the maxillary alveolus, communicating it with the floor of the sinus, and this is what we see in odontogenic sinusitis. So this means that this patient doesn't need an ENT surgeon. They need what? They need a max-fac surgeon or a dental surgeon to remove this tooth. So we don't need uncinectomy, we don't need FES, it's just remove the tooth and the patient will be fine. Patient with difficult extraction of the left upper first molar, and what can we see here? This is a retained root fragment, right? And causing inflammation in the sinus because it has been displaced upwards into the cavity. And you need to look for the defect because it will escape through a defect. So this is an oroantral fistula. This was an interesting one. So patient with chronic right nasal obstruction, lesion bulging into the right OMC, osteometer complex, on nasendoscopy. So what is wrong here? There is a tooth in the wrong place. It shouldn't be up here, right? And this tooth is surrounded by another wall. So it's like a sinus within the sinus. But how can we explain that? Let's see the sagittal. So we have a missing tooth, which is an unerupted tooth. This is the wisdom tooth. And it's surrounded by a big cyst, which has an airflow level inside, which means that this unerupted tooth is surrounded by what? A dentigerous cyst, which is very commonly seen in cases of unerupted teeth. It usually encases just the crown of the tooth. And how can we explain the airflow level there? Sometimes this cyst can rupture into the sinus and cause communication between the sinus cavity and the cyst itself, and that's exactly what has happened here. Developmental issues. These actually can present later on in life. It doesn't need to be during infancy. And be careful, not every polyp is a polyp. It can be something else. It can be a tumor, it can be a developmental anomaly. So you need to be cautious before calling anything in the nasal cavity or the sinuses a polyp. And you need to pay attention for just one lesion in the sinuses, because most of the sinus issues is actually systemic problems, like allergy, right? Infection. But if you see just one polyp, this means that the chances of being a malignant lesion or even a benign tumor are higher, or it can be a developmental problem. And in these cases, if we're suspecting a developmental issue, we'll need a CT and MRI to make a definite diagnosis. So I'll show you a few examples. Say a patient who is a young boy, 7 years of age, and this boy was planned for surgery just the next day. And the ENT surgeon, it was just like a gut feeling, came to me asking, she didn't feel that there's something not right. So she asked me just to review the scan again. It has been reported as a polyp. And I see why it was reported as a polyp. It's a very well-defined thing. So this is sagittal T1 empurage post-contrast, very well-defined thing with enhancing mucosa, no solid components, looks very innocent, expanding the sinuses, the nasal cavity posteriorly. But there was something there on the coronal which doesn't look right. The brain parenchyma was being tethered, dragged downwards. So we shouldn't see that, right? So this means that this is actually a defect. There's a defect in the nasal roof through which this CSF-filled cavity is descending, and the defect needs to be seen better. You'll see it better with your CT rather than MR. So this was a frontoethmoidal meningocele. A companion case, just to show you that also sometimes the brain can herniate, and this is usually a bigger defect here. You can see some brain tissue laterally or peripherally within this defect. So this is what we see in a meningoencephalocele. This is a patient with Apert syndrome, and this is one of the midfacial anomalies. You can see that the patient had previous surgeries in the past. You can see the surgical clips in the zygomatic bones bilaterally. And if you look carefully here, what is that? So this is your nasal aperture. It normally should be more than 11 millimeters, right? But now it's very narrow, it's slit-like, and on the coronal, again, you can see it's slit-like. You can see a defect in the nasal septum, which is probably post-op. And this is what we see in congenital nasal piriform aperture stenosis, and we see that in many cases of midfacial anomalies as well. Patient with a known syndrome, and we will give you the diagnosis at the end. You can see the hyperostosis in the bones. It can affect the skull base, it can affect all the facial bones, and can you see the nasal apertures very, very thin, very tight, right? If I was an ENT surgeon, I would not like to see this patient. If you need to fez this patient, it will be a nightmare, right? So, and actually, this is a systemic problem, congenital in all the bones. Even the long bones will be affected. Instead of having the normal convex in the diaphyses, convexity, it will be, instead of the concavity, it will be convex outwards. And this is what we see in Engelmann's disease. It can affect the skull base. All the foramina can be affected. Cranial nerves can be involved as well. Patient with unilateral rhinorrhea, and this patient presented later on. This was about in his 20s or 30s. And you can see the problem. Where's the problem? It's in the posterior choana. It should be more than 3 millimeters, and here it's completely blocked. But this is not bony. This is membranous. Okay, the surgical approach will be slightly different if it is bony, like in this case. Again, the similar history, and this is a bony chondrotresia. Now a different topic, wall destruction. Wall destruction is very common in cancers, but you still can see that in benign cases. Make sure that there is no mass before calling it benign. You need to check carefully. History, you need to check prior imaging, make sure that this is not cancer, because most of the cases of bony destruction, the main reason will be cancer, right? And that's why we said history is very crucial. And CT is usually enough to make a diagnosis in these cases. Patient found collapse outside a pub. This was a young man. What's wrong here? We have bilateral basal ganglia bleeds, right? What's the most common cause of basal ganglia bleed? Hypertension, right? Yes. So we need to find out why this patient, young patient, had all of a sudden his blood pressure just shot up, right? And the clue was on the scan itself. What's wrong? Nasal septum, where is it? There's a defect in the cartilaginous nasal septum, which we see in some of the recreational drugs, especially cocaine, right? So this can be a clue on your the same scan. You don't need to scan the patient again, especially if the patient is very unwell, like this patient here. You will have a clue there. And this means that you'll need to ask your A&E consultants to take bloods for toxicology screening. Patient with chronic sinus problems, and here all the sinuses are involved. Hyperestosis, inflamed, completely opacified, right? And where's the bony nasal septum? It's completely gone, right? And this is what we see in cases of GPA. And in these cases, look for mucoceles as well. It's very common to have mucoceles. Previous radiotherapy and surgery for right sinonasal cancer 7 years ago. We're seeing this now more often because of the better medical and surgical management that we have nowadays. So patient will survive longer. That's why we see ORN more often now. And here you can see moth-eaten appearances in the maxilla, so in the floor of the orbit and in the lateral wall of the maxillary sinus. So these are all signs of ORN, but you need to be very careful because there may be recurrence there. You need to get the old scans, compare with it. Make sure that there's no new mass. If you're not sure, bring the patient back for an MR, give GAD. Okay, because if you say ORN, the management will be completely different from recurrence. Now let's discuss patients with blocked sinuses. Chronic obstruction usually causes mucoceles, but also sometimes for unknown reasons, this can cause shrinkage, especially in the maxillary sinus, and this is what we call silent sinus syndrome. Make sure that there is no mass causing the mucocele. That if the maxillary osum is blocked or the frontal ethmoidal recess, the frontal recess is blocked, this can cause mucocele, but you need to be 100% sure that there's no mass there blocking the sinus. So we'll need, if you suspect that there's something else happening there, an MR with contrast will tell you the answer. And CT can actually overestimate the wall breach. And if you're not sure whether or not this sinus, this expanded sinus wall is intact or not, bring the patient back for an MR. Patient with chronic headache, and what's wrong here? You can see that the uncinate process on the symptomatic side, so the right side, is lateralized, which caused the ethmoidal infundibulum to be very tight, and you can see that the sinus started to shrink. So the orbital floor has gone down, the lateral of the sinus has gone in, and on the axials as well, the same thing. All of the walls are shrinking inside, and this is what we see in silent sinus syndrome. The other extreme is expansion, which is way more common. So the frontal sinus is the most common sinus involved in a mucocele. And here, what could you see here on this MR? So an expanded frontal sinus, the wall is intact, right? CT can be deceiving, but the MR will tell you whether or not the wall is intact. High on T2, and this is T1 without contrast because of the thick proteinaceous contents. Sometimes you can get high T1 signal. And you need to give GAD if you suspect that there is a, oh, is that a fire alarm? No? You need to check that there's no mass blocking the sinus, right? There's nothing there. And of course, because of high T1, you will not appreciate the enhancement that good anyway. So this is expansion, so this is a mucocele. Another patient with chronic sinus problems and right proptosis. And here we have a mucocele in the anterior ethmoidal air cells, but look elsewhere in the sinuses. All the sinuses are involved, so there's something more severe, I would say, happening, right? And look at the coronal, again, expansion, but look at the septum. It's eroded. What's the diagnosis here? GPA, granulomatosis with polyangiitis. This is what we used to call vagueness. Patient with blocked right nose and headache. Again, expansion in the sinus, T2, high signal intensity. You can see that the middle meatus is pushed medially, the nasal septum is pushed medially. On T1WI, it's a flow signal. You can see that the mucosa is still there, thickened. Give contrast to make sure that there's no enhancing mass lesion here. And this was just a simple mucocele. Sphenoid sinuses, mucoceles are very rare. These are the rarest. Headache, double vision. So let's just go back to this CT. Can you see that the wall, you can't really make sure if the wall is intact or not. But as we said, just bring these patients back for MR, and you can see that the walls are intact. High T2, low T1, give GAD, no enhancing mass lesion in the sphenoethmoidal recess, and this is what you see in just a simple mucocele. This is an interesting case, patient with headache, and this was reported as a polyp. Would we agree with that? If this was a polyp, how can we explain that? Why is a polyp surrounded by bone? It doesn't make sense, right? It shouldn't be surrounded by bone. Let's see the coronal. So this lesion is actually going into the anterior ethmoidal air cells and inferiorly into the maxillary sinus. So it has communication between both sinuses. How can we make sense of that? Hallerson, who said that? ENT surgeon here. Well done. Haller cells. So Haller cells are infraorbital ethmoids. So from the anterior ethmoid air cells, sometimes you can get Haller cells. And if these cells are blocked, what's going to happen? They will expand both ways, go up and down. And this is what we see in mucocele of Haller cells. These are very rare, right? Yes. Patient with right-sided nasal polyp, clinically maybe polyp, and query malignancy. And again, this was reported as a polyp, but the same mistake here. Why is there bone? And the clue was actually on the same scan, the same image. What's wrong here? We have a concave losa, right? So this was another concave losa, and you can see on the axil, you can see the expansion. On T2WI, very bright. On T1 with contrast, there's no enhancement there. So this was a simple mucocele of a concave losa. This is, I think, the last case. 45-year-old patient. This was a very interesting case. It took us a while to decipher what's happening here. Painless left orbital cellulitis. This is unheard of, right? Orbital cellulitis, the patient will be very unwell, septic, in severe pain. They don't even want to talk to you, right? And here you can see expansion in the frontal and the maxillary sinus, and the rest of the sinus also are grotty. And the infection has spread through a defect in the bone, and you can see the periorbital abscess, a big abscess, squeezing the eye globe. Can you see that? And on the axil, again, you can see the big abscess in front of the orbit. But you need to ask yourself, why is this patient presenting with painless orbital cellulitis? Why did she wait that long? Any clue? What's that? So this is your Meckel cave, right? So this means that patient cannot feel her V1, right? This is V1 distribution. And we have a mass in the Meckel cave. Does that make sense? It's a trigeminal nerve sheath tumor, right? Schwannoma. And what's there on the rest of the scan? You can see that we have extraaxial lesions, some of which are calcified, right? So what's the diagnosis here? NF2. Well done. And actually, some patients with neurofibromatosis can be diagnosed lately, and maybe you as a radiologist will be the first one to suggest that. It doesn't need to be a child. And this was one of these cases. So, take-home message. Recognizing the pattern of sinus ossification can help you locate the obstructive lesion. Acute infection in the frontal and ethmoid sinus can spread to the orbits and cranial cavity, causing a surgical emergency. So these are no longer ENT patients. These need either, if it is the orbit, ophthalmology help, or if it is a CNS involvement, this will be a neurosurgical case. Odontogenic infection in the maxillary sinus is managed differently, so these are managed by max-fac surgeons. Osteomalacia of the skull base, secondary sinusitis, can be easily missed on CT. If you suspect it, just bring the patient back for an MR. Invasive fungal sinusitis behaves like cancer, but always remember fungus should not enhance, cancers will. In case of mucocele, the lack of sinus wall perception on CT does not mean that the wall has been breached. Most of the cases, the wall will be completely fine, but you can't see it. MRI is way better to assess cortical integrity, dural breach, and intracranial extension better than CT. But both modalities actually will complement each other, so it's very often that patient with CT will need to come back for an MR. By this, I'd like to finish, and thank you for your attention.
Thank you, Dr. Alaa, for these captivating and case-stimulating lectures.